Okay, good morning. It's Jason Renault with the Alternative Mobile Services Association. I'm here with another episode of AMSA Talks with Dan Petty with the City of Madison and the CARE program. Hey, Dan,
Hello, how are you?
doing well. Today we're going to talk about data. And Dan, you're the data analyst for Madison, and this is a coveted position. Many ta agencies, teams around the country are really interested in having an expert join their team to talk data and to crunch their numbers, do the math. Why don't you start out by telling me a little bit about you and about how you got to Madison?
Yeah, so I've been in Madison working for the Madison Fire Department for just over a year now, a year and 3 days. I came here from Tempe, Arizona, where I worked as a data analyst for the Tempe Fire Department. I spent some time there as an intern and eventually kind of worked my way into a full-time position analyzing EMS and fire data for the community medicine program that we had in Tempe. But the CARES program in Madison was looking for a data analyst that also could work with Madison Fire Department data and Madison EMS data. So I kind of leaped at the chance to work here and work for this really innovative alternative response team. Seeing the work that they were doing, so I came out here a year ago to really just help them with analyze their data and kind of tell the story of the program and the department as a whole. That's kind of one of the things I kind of lean on as a data analyst. With CARES program last year ran 3,500 calls. How do you describe that? How do you summarize that? And that's kind of my role to tell the story of what the program does and how it does it and when and where and all those questions.
So, does your scope of work include other parts of the fire department, or are you exclusive to CARES?
I spend a good chunk of my time on the CARES program, but I'm available at the fire chief's request for all kinds of different EMS and fire related issues. Whether it's one of the big things that I worked on recently is the department decided to move an ambulance from one location to another and assessing the impact of that on response times and how busy all the other units are. But a good chunk of my time is spent on the CARES program, but there's a lot of other uh, data needs that a fire department has, and I'm well prepared, I think, in my opinion, to kind of deal with those questions. I think the useful, interesting thing about that is the records management is for both, the department as a whole and the CARES program is under the same software. So we use ImageTrend for capturing EMS data, fire data, and the CARES program data. So I'm kind of drinking from the same spigot when it comes to data. So it's helpful in that regard that there's some similarities in the data, even though the function and the utility are different.
So you were familiar with the technology from your prior position and ready to go on day one. That's pretty exceptional. Now, before we go into the data, some of our viewers might not really know Madison. So you have some fresh eyes. You've been there for a year. Tell us a little bit about Madison and the sort of challenges of doing operations there.
So Madison's a city of 280,000 or so people. It's the capital of Wisconsin. We've got the capital here. We've got the county, Dane County's public health is very involved in the work we do here. We've got and obviously the city leadership. So there's a lot of interest, a lot of stakeholders for this particular program in the CARES program. A lot of people that are interested in it. And it's a very high profile uh, program. So there's a lot of eyeballs on what it's doing, and everyone universally is very proud of it, and I think the success it's had. But the challenge for me is just making sure that we have the data, the right data to kind of tell the story of how we're doing it.
So let's talk about that data. You mentioned a software platform that you are using there. Could you tell us a little bit about that?
Yeah, so ImageTrend is a records management system for it caters to the fire service, but there are other agencies and EMS agencies that use it. Our everyday fire trucks, fire engines, fire ladders, they use ImageTrend to track their events, their incidents, and with the schema, there's the National Fire Incident Reporting System.
Hmm.
NIFRS is the acronym. And that's the same with the CARES program. They are dispatched and respond, and they have on-scene times and all those fun things that a fire unit would have. And then also on the EMS side, all the patient care reports are done for the EMS units and also for the CARES units under that software. So it was something that's familiar enough for me coming from Tempe, where that was a software that Tempe used as well to kind of jump in and be ready day one to help out.
Now, does that software package also contain, say, disposition or healthcare records?
Yeah, it's the records that the CARES program takes is kind of a really modified uh, EMS PCR using the NEMSIS data schema. So there's dispositions, there's primary symptoms, primary impressions, things like that. Some of those are applicable to the kind of calls that CARES goes on. Some of them not so much. There's been some kind of modifications we've had to make. CARES occasionally will respond only over the phone when necessary.
Hmm.
It's not a thing in the EMS world to follow up with a phone call. So there's been some sleight of hand and some manipulation of fields and values to kind of accurately capture what CARES does in this kind of schema. But I think we're not alone in having those kind of challenges as a program. There's really, all these programs are very different. They're all kind of their own unique unicorn, and catering to all of them is a big challenge. So we've shaped our data into what we hope to capture and what we want to capture, and we've got a pretty good record here going back to 2021 that I'm able to, I was a day one able to step in and look at that and analyze, and then going forward merge and mush all those records together in a way that's helpful for telling a story.
Now, many fire departments have follow-up programs to deal with people who are frequent callers to 911 or have set fires for unknown reasons. Does Madison have a program like that?
Yeah, separate from CARES, we have our own community paramedic program that the CARES community paramedics. I can get into the specifics of how the program runs, but they also spend time with those kind of the frequent flyers or follow-ups. So it's that work is done separate from CARES, but it's something that Madison also does, and that was for me. I saw the power of that kind of work in Tempe, and then
Oh,
knowing that Madison has that program as well, in addition to the CARES program, was really appealing to know that we can make an impact on those individuals.
and is this a team approach or is this an individual doing these outreach?
It's a little of both, so that a referral might come from a fire crew,
Hmm.
or they might notice a pattern in utilization, and they'll divvy out the different patients to reach out to amongst themselves. So
Mhm.
um, there's a collaborative approach, but there's also an individual approach as well.
And there's an important part of the CARES ecology, which is the Journeys program.
Yes, yeah, and not to overlook them at all. So the CARES responds with two people. One is a Madison Fire community paramedic, and the other is a crisis worker from Journey Mental Health, which is a mental health organization here in Madison that serves Dane County. Um, they respond together. It's two different entities working together to work together on these the calls that they CARES gets dispatched on. So there's kind of a challenging issue there where you've got two different data sets. I've leaned being under the fire department. I've leaned heavily on our Madison Fire Department data, knowing that it more or less is going to reflect what Journey captures, but trying to overcomplicate things by drinking from two different spigots, so to speak, can be a challenge. So I speak a little bit in the fire department lingo. I talk about patients. I talk about response times and things like that are a little different than the work that the crisis workers are used to. They're talking about clients and things like that. So some of the language can be a little challenging at times. But yeah, it's a collaborative effort between those two organizations to run this program.
So there's really two separate data collection processes, and privacy is a big component of that. You can't, you're not a medical provider as the fire department, you're not a medical warehouse, so you're not covered by HIPAA. Is that correct?
Oh, no, no. So we are covered. Yeah. So we
Okay,
bill for ambulance services. So
because you're paramedics, right?
yes, paramedics. Yeah. So there's no billing for CARES calls, but we're one under that umbrella of coverage as a I forgot the terminology. HIPAA covered entity.
And but you can't commingle these two databases. They have to remain distinct.
Exactly. Yeah. It's not something I can cross lines and tap into their data easily without um, not I just it's not something we do because of those kind of issues. There's a lot of protected health information in their data warehouse, and then in ours as well. Functionally in the field, these aren't issues, but for a data analyst like myself, like it's a challenge, and then that one of the ways to resolve that is just to pick one source of truth, and that's in this situation I lean heavily on Madison Fire's data because that's the data I have access to,
Mhm.
and I'm familiar with, and it's collected in a way that's consistent with other data in the department.
And last question before we jump into you're showing us some of the dashboard. You came in. This was already an underway project when you came in. Chief Stedman had done some great work at putting together an online real-time dashboard.
Yeah, and so I inherited some data practices that got passed along as far as reporting and the decisions on what data to collect and what questions and what values to have. That was well underway. So it's trying to mix the work that's been done before with the work that I'm doing going forward. There's been some decisions I've had to make here and there as far as uh, how the data is collected and things like that, and how it's tabulated. But it's there was a lot of work done before me, so I was really lucky in that regard to land in a situation where there was a big pile of data that needed someone who could dive into it and analyze it. But the fortunate thing is, it was there.
Terrific. Well, let's dive in. Want to show us your database and
Sure,
your dashboard?
sure. So the one that I want to highlight first, our dispatch has done a great job of listening to some of the concerns about from our leadership about what calls is CARES not available to take. They have a schedule that goes from 8 to 9 p.m. Monday through Friday, and then on weekends they have a unit from 10 to 8 p.m. So there's limited coverage on weekends. Their dispatchers have done a great job. They've adapted to this kind of request on our end to note in their dispatch records when they would have dispatched CARES, but they couldn't. And that's helped to answer a lot of questions about what are we missing? Where is the demand that we're not able to meet? This to kind of guide you through here. So this data goes from this is when they started, the end of January.
Mm.
This is the most recent data poll that I did earlier. And you can see here that I'll toggle for the weekdays. We've got a lot of calls here that come in at 9 a.m. that we're not able to meet. Sometimes that's because there's another unit or the lone unit available at that time is already on a call. Um, but you see, as the day goes on, as we have these staggered shifts overlap in the middle of the day, it's very rare for us to miss a call. So I think this helps kind of inform, all right, if we were going to shift our coverage, if we were going to expand our coverage, we want to go out maybe just a little bit on the edges, maybe a little earlier in the morning or a little later at night. The idea that it's been floated around and it's nowhere near a consideration, or I don't think in any meaningful way, is having a 24-hour unit.
Hmm.
It's easy to kind of, in my mind's eye, to imagine someone having a mental health crisis at 2 a.m. But the data doesn't really show that there's a lot of demand in these wee hours here over these last 5 months or so to support a 24-hour unit.
Yeah, it
This
seems the bigger the city, the more likely it is you're going to need 24 hours. But really, where you need it is at 9 a.m.
Yeah, yep. So
Yeah.
that's a lot of these tend to be early in the morning. We'll get welfare check calls for if someone missed an appointment or they didn't show up to
Hmm.
work. That's kind of what's being reflected here. As we flip over to the weekend, we see kind of a more broad uh, coverage. We could conceivably catch these with another unit. From 9 a.m. to 9 p.m. Another unit might catch these. We average more missed calls on the weekend than we do during the weekdays. So I think, I can't say that this has led to an immediate decision already of that nature, but this has helped kind of inform our leadership on, all right, what could we be missing? What might we consider doing when it comes to expanding hours or changing hours?
Absolutely.
Um,
Yeah. Great.
uh, One other thing I kind of want to highlight, and I think this is kind of um, like I guess a philosophy of mine as a data analyst, if I'm if I can allowed to have that in the time I've had as a data analyst. Um, a lot of times the work that I do is to reduce or prevent us from saying like meaningless but kind of fires like more and more all the time or every day.
Mm.
Being able to have an exact number or uh, a meaningful number about things is kind of how I view my role, and also the ability to kind of prevent anecdotes from becoming narrative, becoming reality. So one of the things I want to highlight with this is the department decided to move all our three CARES units under one roof in a central location that previously they'd been spread in two separate locations, so west side and the east side.
Mm-hmm.
The fear was right when that happened that we might get fewer calls from the west side. They might think the CARES team is too far away, and that's a reasonable concern. Many of our calls come from police officers radioing and asking for CARES, or from Madison Fire units requesting CARES, and that concern kind of lingered as we started to implement it. But I think one of the ways that I was able to kind of ease concerns with that, and I'm going to show a map here of Madison. These are the uh, I work with what I have. This is Power BI. This is the best I can kind of do. This is a heat map here of Madison. This is a heat map here of the different police districts here in Madison. There's a central, east, midtown, north, south, and west. The concern was that units with a centralized CARES unit or CARES units here downtown, that these calls on the west side would drop off or be ignored. And I was able to show with this pretty simple map, there's nothing magical here. This is just looking at latitude and longitudes of calls that, well, in 2023, 16% of our calls came from the west side. 2024, that stayed precisely the same. And here in 2025, with the move happening late last year, we've actually increased our proportion of calls in this far west side. So this doesn't beat back the hypothetical anecdote of a police officer not wanting to request CARES, thinking it's going to take 30 minutes for them to drive across the town. But it does show that, look, if there is an impact of moving the units under one roof, it's not obvious in the trend. So this has been a kind of a useful map and visualization for me to kind of prevent that anecdote from becoming reality or that concern from being reality.
Sure.
Uh,
It really helps manage the expectations of the public when you can show them an image like this and say, we do have coverage in this. So you have real conformity in this map between 2022 and 2025. 2021 outlier, probably COVID. That's really
well, so yeah,
interesting pattern.
yeah, the consistency of some of these things is pretty astounding at times when you consider that I plopped in and started looking at these things after this data was already collected. So part of what's going on in 2021 is the program started in September. It was limited to the downtown area
Ah,
initially, and then it expanded out.
okay.
So that's part of that. But there's been many times where I've calculated a metric. And looked at how consistent it's been, this metric that no one's looked at, that no one was calculating. We have this kind of interesting program that takes all kinds of different calls, has all kinds of different outcomes, but in some ways, the consistency is always pretty amazing. That's true is with the EMS data as well.
Ah, okay.
So another thing to highlight with this, and this is nothing magical, but just looking at um, some of our response times. This is going back. So we've got a 90th percentile response time. That's a good example of fire department lingo that is maybe a little foreign to some members of crisis response units. But in looking at our average response time in here in minutes, the move to the central location was done in October.
Okay.
There's barely a budge.
Nothing.
There's barely any movement. You know how consistent this is. I would have honestly wagered against this. I would have thought perhaps there'd be a slight increase, but there really hasn't been any demonstrable impact on response times by having us under one roof. And there are a lot of caveats with this data. And there's as far as there are times where the units will try to initiate responses over the phone and then do a physical response. So there's aspects of this that as a fire department data analyst that I never have to consider. A fire engine gets dispatched and they go. Uh, Whereas here I've got a lot of asterisks that I have to think about and consider as far as how to fairly represent our response time when it comes to crisis response.
Are you able to show us your call disposition?
Let's see here. Let's move it. I'll look here on the other monitor and see the best kind of way to do that. Yeah, let's go to slide 8. All right, got a lot here. I won't claim to be the prettiest when it comes to visualizations, but the info's here. So up here we've got our patient contact percentage. It's Many of these check welfare calls won't necessarily result in patient contact, or if someone's acting strangely on a street corner. By the time we get there, they may not be there. So that explains some of this lower percent, or the perhaps I think lower percentage than perhaps some folks might expect. We also have this percentage of calls handled without other units. This is a metric. This is a good example of one that wasn't calculated till I came here. I calculated this going back to 2021 using timestamps we have from our dispatch center. It stayed remarkably steady. There's movement here, but this is a 20 points of percentage here going month by month. So around a little less than 2/3 of the time, they're able to handle calls by themselves with no other units on scene. If we look at kind of the flip side of that, how often does a CARES unit arrive on scene and then a PD or fire or EMS unit arrive after that?
Hmm.
That percentage is much, much lower. It's, I believe,
Okay.
93% of the time CARES, once they're on scene, no other emergency responses are needed. So this metric has been kind of a tricky one to figure out. There's the desire to kind of look at intention after the fact. Was it was CARES requesting police because they need them urgently because of a safety issue, or is CARES requesting police because they need to gain entry on a check welfare and they need police's help to do that? So there's a lot of grayness in that number, and kind of trying to find a metric that I can kind of lean on and state with some definitive nature that, all right, I can look at how often is CARES on scene by themselves, and then report out on that, and then we can, if we need to dive into that and look deeper, that's available. But it's
Well,
so
that
much of
grain,
this.
this is always the process with analysis, is that grayness becomes granularity as you start to say, what is the data that we're looking for here? What is the argument we're trying to make?
Yeah,
And if the argument is police are important in this process, they're an important part of this continuum, well, that's a data point to pull out. But if the argument is to make, well, we're trying to be a full alternative to police, maybe we need more resources.
yeah, yeah. And that going forward with this kind of analysis, I think, uh, I, the how stable this percentage has been over the years through
Hmm.
different staff and through different dispatchers and through different perceptions of cares maybe.
Uh-huh.
It's been kind of an interesting fact. So um, and in addition to that, there we've got our disposition, probably more granular on these than maybe they need to be, but you can see here that uh, CARES transports about a quarter of the time when they make patient contact. There's a percentage of time that we're able to resolve it over the phone, 20% or so, 1 out of every 5 when it comes to making patient contact. And then the one that was highlighted really from the beginning is transported by law enforcement, and this has
Really
been
low.
a low percentage,
Really
1%,
low.
2%, and we
That's great.
make an effort to track. All right, what does that mean? This doesn't necessarily mean you're arrested and you're going to jail. This is
Uh-huh.
you might be in protective custody. You know there's caveats with that number as well, but that's
Yeah.
it's low to start with, and we do track those individual incidents and try to make sure we can speak with some authority about, all right, these are this doesn't necessarily mean they were arrested. It just means that law enforcement was necessary in those situations.
What I'm not seeing in the disposition by month that I've seen in other charts is we went out to see this guy and he just wasn't there.
So that would be the inverse of this one up here. So
Okay.
um, it's a
Okay. So you're
yeah. So
contacting in May 57% of the people who you went to see you made
yeah,
contact with. Okay.
yeah. And out of that 57%, here are the outcomes
That's about
here.
right. Okay. Okay.
Yeah,
I get it.
yeah, yeah. And this kind of shows too that the difference between an alternative response and an EMS agency or even police. There's a wide variety of different places that people might end up. So this is a challenging one. So I think we're happy with this emergency room being. Sometimes it's a slight majority, but and it's the most of the options. It's the most common sometimes, but if when Madison Fire makes patient contact in an EMS context, that they transport them to the ER about
100%.
85 to
Yeah.
88% of the time. The fact that we're uh, transporting only 25% of the time or less than that, and out of that, slightly close to 50% of those go to the ER, and then there's other options that that aren't available in other modes of response. So yeah, this is the data we kind of focus on. I think this bounces around perhaps month to month more than we need to, but we can speak with some authority on what we're doing based on the tracking we're doing.
Great. Great. Okay. This looks terrific, Dan. Well, thanks so much for showing us that. I have one more question for you, but maybe we'll get the slide off the screen
Sure. Let
and go
me.
back to our meeting. Um, here's a question that I get asked a lot, but I don't know the answer to, which what's the future of artificial intelligence here?
Gosh. Okay. So I think that the immediate next 5 years kind of approach for, and this is coming with an EMS uh, mind first, I guess, the ability to have a narrative written out of a PCR or something that's offered by multiple uh, records management systems right now that can look at the values you put in for uh, you know disposition, the value for primary impression, the vitals, the meds you gave, and take all that information and weave it into an accurate paragraph or two of a narrative that a medic can work on without having to start from scratch. That's an
1,000
immediate thing.
pages of EHR. Yeah.
Yeah,
Yeah.
that's an
That's great.
immediate, and then I think it's there's some vendors that do it right now. So that's a kind of the immediate thing.
Let me ask
I've
just a detailed question about that. Would that be able to read across these different databases we described earlier?
In this kind of the context I'm thinking of, it would be only solely focused on that provider's one encounter. But theoretically, you could open that up to more. I think the one context that I had that I was able to implement in Tempe that I still haven't really it hasn't clicked here. Uh, in Tempe, we were taking the EMS runs we had every day, analyzing those, the values, the narratives, taking that and then putting it up against a machine learning model that I built, nothing fancy. Anyone with experience with that could do it, and then spitting out from there, all right, who are the most likely people to call 911 in the next 30 days? And from there, you've got your referrals. There, you've got your future frequents. They may have only had 2 calls in the last weekend, but people that do that tend to have more calls in the future than somebody who hasn't. So it puts people on your radar that doesn't require a fire crew, assessing an immediate need or recognizing a pattern of utilization, kind of looking at a global, not global, but a citywide view of our runs and our patients and on who has the most acute need based on this model. So that's something I implemented in Tempe. I'm really proud of that work. Haven't quite clicked because crisis world's a little different. Like it's not not a perfect fit for this kind of response. So, but that's a doable thing now. As far as the future with AI, gosh, I don't know. It's hard to see that far, but I think assisting responders with their documentation, I think that's a near term, next week sort of thing.
Yeah, I've heard that a lot of police reporting, police documentation is going to shift to AI in the next few years, and just this repetitive writing, this able to just click yes, this happened, this happened, this happened, and create a document that's a little bit more grammatically correct.
Yes, for better for worse, that it's still got your name on it. You're still signing to it.
Yep.
There's
Witnessing
all
it.
those challenges, but that would be the immediate thing that comes to mind. But I really uniting all these kind of patient databases and uniting having these larger health information exchange, theoretically could really have an impact in the field if we were able to have better access to the databases we ought to have access to. I'm not proposing anything outside of that, as far as looking at patient history or prior contacts, things like that would be a big step, and that would require some computing power, but that's not necessarily AI. But those are, I think, are the near term kind of goals.
And what's next for Madison Cares?
Uh, in this funding uncertainty, I think staying the course is a success. We had an expansion. We expanded into the neighboring city of Sun Prairie in
Right.
February. We've had some like success with that early on. I think there's a learning curve as far as knowing that the CARES exists and what are the appropriate ways and means to call. Um, excuse me. But we've had expansion in the recent past, and it's been a success. There's been some talk about continuing that expansion. The idea that with it being a success in Madison, the idea of having another community try to reinvent it from scratch again when there's the personnel and the capability down the street, that's that's on the front burner, I think, in some ways.
This is one of the most exciting things about Madison to me is I talked to Mayor Rose Conway about this about a year ago. She was just super excited that Sun Prairie was coming in and that perhaps the CARES model could continue to expand into other municipalities in Dane County.
Yeah, yeah, and then that's I think it's finally starting to click in Sun Prairie. We saw maybe about half of our responses to them have been in the last month or so. So it's been it's a learning curve, but it bodes well, I think, for this model and this idea. It makes so much sense on paper that it's hard not to want to implement it elsewhere.
Yeah, it doesn't make sense on paper for really small towns, though. So if an adjoining city can say, "Okay, we'll bring you into to our workforce," that's terrific. Well, thanks, Dan. Thanks for showing us your dashboard and your data.
Thank you for having me.
Okay, take care.